Welcome to Pharmacology Mini number 7, where we'll talk about antipsychotic medications. Antipsychotic medications aim to manage symptoms of psychosis and schizophrenia and can also be helpful in the treatment of bipolar disorder, Tourette syndrome, agitation, extreme nausea and vomiting, and hiccups. The way that it works is it blocks dopamine, acetylcholine, histamine, and norepinephrine. There's 3 different categories of antipsychotics, including first generation, which only treat the positive symptoms of schizophrenia, second generation, which treats the positive and negative symptoms of schizophrenia, and third generation, which also treats the positive and negative symptoms of schizophrenia. When we talk about first generation antipsychotics, sometimes they're also called conventional antipsychotics. As I mentioned already, they only treat positive symptoms. So that's going to be your hallucinations, your delusions, and some of the behavioral and thought processes that we see with schizophrenia. Examples of this include chlorpromazine, which is Thorazine. Thorazine in particular is used most often when our patients have an aggressive type schizophrenia, which is more rare, but sometimes is seen. We have haloperidol, also called Haldol, fluphenazine, also called Prolixin, theothixine, also called Naving, perfenazine, also called Trilafon, loxapine, also called Adasuve, and triflupizine, also called Stelazine. The side effects of first-generation antipsychotics include severe extrapyramidal symptoms, which we'll talk about in a little bit, neuroleptic malignant syndrome, which is a medical emergency. It can also cause anticholinergic effects, gynecomastia, and galactorrhea, which is production of breast milk even in males, and breast growth as well. We can see seizures, photosensitivity, contact dermatitis, orthostatic hypotension, sedation, sexual dysfunction, agranulocytosis, so we would want to monitor their blood counts, dysrhythmias, and liver dysfunction. Extrapyramidal symptoms are a very severe side effect that we commonly see with first-generation antipsychotics. This includes a couple of different movement-related disorders or side effects, including acute dystonia, which is spasms of the tongue, the neck, the face, and the back. This may cause permanent stiffening in their neck, so their head may be angled at different angles. And if they have spasms of the tongue and the neck, it can cause difficulty breathing. So we would want to monitor for any of that, and they may need respiratory support. It typically develops a few hours to 5 days after their first dose, and it's treated with Benadryl or Cogentin. Parkinsonism is another EPS symptom, and they develop bradykinesia, rigidity, shuffling gait, drooling, and tremors. This typically develops within about 1 month of treatment, and it's treated with Benadryl, Cogentin, and nimantadine. Akathisia is another EPS symptom, and in that we see restlessness, so they may have inability to sit still, pacing around, things like that. Typically develops within 2 months of starting treatment, and it can be treated with a beta blocker, a benzodiazepine, or an anticholinergic medication. Tardive dyskinesia is involuntary mouth, tongue, face, and lip movements. It can also include involuntary arm, leg, or trunk movements. It can develop months to years after initiation of treatment, and it's treated with a new medication called valbenzine. The last one is oculogyrocrisis, and this is eyeball spasms that can leave the eyeball in a fixed location rather than being able to move around. Treatment for this would be Benadryl or Cogentin IM or IV. Neuroleptic malignancy syndrome is the medical emergency that I mentioned, and this happens almost as a reaction to the medications where the muscle filaments get stuck. So typically when you contract and relax a muscle, the filaments slide over each other and then relax. So with neuroleptic malignant syndrome, those muscles are unable to relax, and that contributes to the worsening of symptoms. So our early symptoms are going to be jaw stiffness and tongue swelling, which can obstruct airflow. They're going to have some slurred speech because of that tongue swelling. they're going to start to develop a fever and have flu-like symptoms. Because those muscles aren't relaxing, they're producing a lot of energy, and energy produces heat. So they start to develop even higher temperature, and their body is going to try and lower that temperature down. So you're going to see things like extreme diaphoresis. You may see some blood pressure changes, but the body compensation isn't going to be effective. So the blood or the temperature is going to continue to increase, and this is going to lead to hyperthermia. And typically we'll see dysrhythmias, further muscle rigidity. They can develop a coma, seizures, and death. The treatment for NMS is to stop the medication, monitor their vital signs, put them under a cooling blanket, and give them antipyretics. We would want to give them fluids. We can give them benzodiazepines for anxiety because, as you can imagine, having extreme muscle rigidity and being unable to relax any of your muscles could cause severe anxiety. We can give them Benadryl or Cogentin for reversal of symptoms. We can give them dantrolene or bromocriptine for muscle relaxation. And we're going to want to put them on a cardiac monitor and help with any antiarrhythmic control that they need. Then we have our first generation considerations. So contraindications to first generation antipsychotics would be things like the patient's comatose, they have Parkinson's disease, liver damage, breast cancer, and we would want to use it in caution with older adults, those with glaucoma, paralytic ileus, BPH, heart disease, liver disease, kidney disease, and seizures. Interactions with first-generation antipsychotics include any anticholinergic agents. We do see additive effects with CNS depressants, and they are counteracted by levodopa. As far as administration goes, like I said, first-generation antipsychotics may be used more often for violent-type psychosis because it only treats part of the symptoms of schizophrenia and has such severe side effects, especially with that EPS. We would typically do a second generation or a third generation first, unless the patient can really tolerate a first generation and the second generations have not been very effective for them. If they do develop EPS, or even if they don't, we're going to assess for EPS using the AIM scale. Antipsychotics can be given PO, IM, or IV, or we can give it in a depot injection, which is administered every 2 to 4 weeks. We also want to be aware of medication compliance. Because these individuals experience such severe side effects, they may not want to take the medication as prescribed. And also, if they develop symptoms of paranoia, they may be fearful of taking the medication. So it's really important that we use our education and our therapeutic relationship with our patients to improve medication compliance and in finding a medication that's going to work best for them and a route that's going to work best for them. As far as education goes, we'd want to educate them on any side effects, liver and kidney function. We would want to educate them that these medications do not cause addiction. We would want to educate them on compliance techniques. They may experience some weight gain. And we'd also want to educate them that this does not cure schizophrenia. It just makes the symptoms more tolerable and less severe and could prevent relapse of psychosis. So moving on to the second and third generation antipsychotics, also called atypical antipsychotics. These treat positive and negative symptoms. They tend to have less side effects, and they could have neurocognitive protection. They work by blocking serotonin and dopamine. However, they don't block dopamine as much as the first generation antipsychotics. So we see a lot less of those EPS symptoms in second and third generations. It also blocks norepinephrine, histamine, and acetylcholine. Most second and third generation antipsychotics end with the phrase apine or idone. Examples of this is olanzapine, also called Zyprexa, quetiapine, which is also called Seroquel, ziprasidone, also called Geodon, clozapine, also called Clozaril, acenapine, also called Sapphirus, lorazepam, also called Latuda, palperidone, also called Invega, iliperidone, also called Fanapt, aripiprazole, also called Abilify, brexpiprazole, also called Rexulti, and cariprazine, also called Vraylar. Considerations for second and third generation antipsychotics is that side effects include development of diabetes mellitus, severe weight gain, and because of this, sometimes our patients that are taking this may also be prescribed an oral anti-diabetic medication alongside, so that it can prevent that weight gain and diabetic development. Other side effects would be hypercholesterolemia, orthostatic hypotension, anticholinergic effects, agitation, dizziness, sedation, some EPS, elevated prolactin. So again, we could see that galactorrhea, gynecomastia, and amenorrhea, and it can lead to sexual dysfunction as well. Most of these are pregnancy category C, except for Latuda and Clozaril, which are category B. It is contraindicated with dementia, and we'd want to educate our patients to avoid alcohol use. We would also want to use cautiously in patients that have CVD, seizure disorder, and the reason for that is because it can increase QT prolongation. Interactions is it can suppress the immune function with anti-cancer medications. It has additive effects with CNS depressants. So again, we've talked about this quite a bit, but it could be alcohol, opioids, or antihistamines. It's counteracted by levodopa, and it can have prolonged QT intervals with tricyclic antidepressants, amiodarone, and clarithromycin. We do see decreased third generation effectiveness with barbiturates and phenytonin. And we also see an increase in third generation levels caused by fluconazole. And that wraps up our discussion on antipsychotics.